Good evening, ladies and gentlemen, Mr. Chairman, and co-faculty, and a number of wonderful doctors who are in the audience whom I had known for a long time. And I'm delighted that they continue to practice and protect the public health in their communities. So I offer my salutations to the medical community of Mumbai, which is a very important place in the country. Now, my task has been made very simple and made very shorter by Dr. Welton and Dr. Joshi. And I mean it, and there's nothing wrong with it. So this will be truly an encapsulated journey of the most recent guidelines for hypertension, European guidelines. There will be some differences with the next guidelines for 2025, ACC American Heart guidelines, and then I don't know what they will say. Only thing that I know is the committee has asked me to review the draft sometime in October or November, and until that time, even after that time, we have to keep our mouth shut until they are released in 2025 American College of Cardiology meeting. So let's move forward. This is a slide that many of you have seen so many times, but it is a so-called healthy reminder. There is a timeline during which complications occur. If I develop high blood pressure today, tomorrow I'm not going to drop dead. If I develop high blood pressure tomorrow, day after tomorrow I'm not going to get CKD. There is a window of opportunity during which cardiovascular risk factors make person as a person is not a patient. So you have an opportunity of several decades during which you can contain and control cardiovascular risk factors before it becomes cardiovascular disease. So a number of people that you see in your practice, they just have risk factors. A good number of them unfortunately end up with atherosclerotic complications. So the goal, you have seen Dr. Parikh introduce the faculty, Dr. Ajit Menon, Dr. Pinto, Dr. Mahajan, how many procedures they have done so far. So my challenge to the audience is to make sure that they don't have to do that many procedures in the future. Let us make them inactive in interventional cardiovascular disease so that you intervene by medical treatment. So that is a challenge we have. So ladies and gentlemen, a very important reminder that it is like a time bomb, but you have some time of opportunity where you can control very aggressively cardiovascular risk factors. Now, this is something that Dr. Welton has already shown, but I have tailored this to Asia and also Australian Pacific. You will see that in Asia, which includes India, that there is a progressive incremental risk of stroke starting with 110, 120, etc., although that is not the goal level of blood pressure at the present time. This is actually is published now 2 years back in the Journal of Hypertension, International Society of Hypertension, and this is the first study that I have done after coming to India 13 years ago, where we did prospective study of risk factors for acute stroke in India, where we look at risk factors for 530 patients who came to Apollo with acute stroke, clinical, and documented by CT or MRI, seen by neurologists, and then we came to what were the predisposing risk factor. As you can see there, the predominant risk factor for acute stroke in India, not surprising, is high blood pressure, followed by people who have high blood pressure and diabetes. So once again, reaffirming what Dr. Welton has said, that the important dominant cause of stroke in the world appears to be high blood pressure, and definitely confirmed in the Indian subcontinent. Now, as I mentioned earlier, our population is growing. The large population is young people, but older people are also living longer and longer, so that you will see more and more people with high blood pressure. It's interesting, there are about 20% of elderly, they never develop hypertension. They never develop hypertension, and I wrote an editorial in the Journal of Hypertension, normotensive aging. How do you identify those people who have normotensive aging? Very, very interesting phenomenon. They never develop hypertension despite aging process. Now, the guidelines have downgraded the definition of hypertension. In the last, since first JNC, the definition of hypertension is being downgraded. The reason why it has been downgraded was now we understand that at any level of blood pressure appears to be a cardiovascular risk, and the lower and lower definitions of hypertension are not made up by the committees, but they are dictated by the available evidence. So this is again suggesting, for example, congestive heart failure. You will see that congestive heart failure, people who have even milder degrees of chronic hypertension, they develop congestive heart failure, other stroke complications. Now, the question comes up, Dr. Ram, what difference does it make if somebody has 2 millimeter increase in blood pressure? Just 2 millimeters. Multiply 2 millimeters by 60 times in 1 minute, and multiply it by 24 hours, and multiply it by 365 days. And that is incremental 2 millimeter geometrical increase of cardiovascular burden that happens over a period of time. Now, this is also shown by Dr. Welton that both coronary heart disease and stroke, the usual BP that we consider as normal can predispose to these risk factors, and that is the reason why new guidelines lowered the definition. Now, atrial fibrillation, a prominent cardiologist there in the faculty and also in the audience, you are seeing more and more people with atrial fibrillation. And a majority of patients who have atrial fibrillation have hypertension. So hypertension and atrial fibrillation go together. And it's very, very important to know atrial fibrillation is a very serious disorder, can be managed, but still is caused by high blood pressure. Dr. Welton mentioned that about cognitive dysfunction. I think Dr. Pinto also mentioned, I talked about it this morning. This is a study looking at elderly people who developed cognitive dysfunction. You will notice that actually they have developed blood pressure before, much before the development of cognitive dysfunction. So ladies and gentlemen, that one of the antecedent risk factors for cognitive dysfunction is the development of high blood pressure in the elderly marker. Now, as Dr. Welton mentioned, guidelines define hypertension. However they define hypertension, the goal level is the same. Indian guidelines, European guidelines, American guidelines, World Health, WHO guidelines, does not matter how they define hypertension. Forget about definition. But the goal blood pressure is in the proximity of 130 by 80. That is the goal blood pressure, irrespective of the definition of hypertension. Now, the previous European guidelines have identified you and me as having 40% higher risk of cardiovascular complications compared to Caucasians. So if you have a genetic background of a South Asian, or let us say Indian, forget about South Asian, Indian, you are at a 40% higher risk of cardiovascular complications. Very, very serious. Similarly, ACC, American Heart Association, in their one of the newsletters, has suggested that the risk of cardiovascular complications is much, much higher among Asians. By that, they mean mostly South Asians. By that, they mostly mean Indians. Now, the latest guidelines, which I'm going to talk about, published in the Journal of Hypertension 3 months ago, and released in European Society of Hypertension last June. I wrote this editorial that is going to appear in the American Journal of Cardiology next month. It is online. The latest hypertension guidelines at a glance, no need for a QR code. It's online. And I wrote the main editorial for the Journal of Hypertension on their paper that they have made it very simple so that you don't have to worry about formula. So I suggested the title, From Encryption to Decryption Finally. So the guidelines are becoming simple and simple. Paul, I hope the 2025 guidelines will be simplest, not simpler, simplest so that people can follow. Now, this is the blood pressure targets for the adult hypertensive population from the European Society of Hypertension guidelines. You will see the target in the light green color, and one should avoid the blood pressure that is less than 120/70. You don't have to worry about it because none of your patients are at the risk of hypotension. All your patients are at the risk of hypertension. The problem in patients with hypertension is high blood pressure, not low blood pressure. So don't worry about hypotension unless the patient is acutely ill. So these are the targets. Now, Dr. Shashank Joshi has shown this already on the pharmacological treatment of hypertension according to European guidelines. For most patients, you start with combination therapy unless somebody is very fragile. And in a number of people, you have to use triple drug combination therapy. So ladies and gentlemen, the combination therapy has become a cornerstone of blood pressure reduction. In fact, I have written to the drug approval regulatory agencies, both in India and US, that they should not approve single molecules for hypertension anymore. They should only approve combination therapies so that people will find it very easy to use. Now, this is a diagram from the European Society of Hypertension guidelines, where you have now RAS blockers, diuretics, CCBs. In contrast to what Dr. Welton has mentioned, European guidelines have upgraded the choice of beta blockers for the initial therapy, not based on any new evidence, but based upon whether the new generation of beta blockers, vasodilating beta blockers, could be more effective, I did write in that editorial that this upgradation occurred without any evidence, but on the pharmacological basis, there is nothing wrong with it. And the diuretics, they have now, instead of saying thiazides, now it's always say thiazide and thiazide-like diuretics. So ladies and gentlemen, this is the diagrammatic representation of the therapeutic choices according to the European guidelines. Now, the European guidelines, when they say thiazide and thiazide-like diuretics, they're mentioning chlorthalidone and indopamide. Beta blockers, they're mentioning about vasodilating beta blockers. So ladies and gentlemen, please allow me to comment a little bit more on these two classes of drug because there is nothing new about other classes of drugs. Now, diuretics. Dr. Joshi talked about Shashank and Dr. Welton talked about it. And this is a study done by Dr. Tarazi and co-workers at Cleveland Clinic. The mechanism of action of diuretics in the treatment of hypertension is a reduction in peripheral vascular resistance, not diuresis. Diuretics reduce peripheral vascular resistance. You look at this slide, when you give a diuretic, the blood pressure goes down, the fluid goes down, peripheral vascular resistance goes down, and then with passage of time, you continue the diuretic, the fluid value becomes normal, but the peripheral vascular resistance remains low. So ladies and gentlemen, one take-home message is the mechanism of action of diuretics is a reduction in peripheral vascular resistance. You cannot have diuresis every day. If you have diuresis every day, you don't live, you die. We don't die from diuretics because there is a new level of sodium balance they reach, but the peripheral vascular resistance remains low. So this is a very important principle that diuretics reduce peripheral vascular resistance like any other antihypertensive drug. Now, this one is a comparison between chlorthalidone and hydrochlorothiazide, not in the same study, but network showing a little bit favorable towards chlorthalidone because of its duration of action. This is something that Dr. Welton has mentioned earlier in the ALL-HAT trial in terms of the new onset of heart failure. Patients who were designated to chlorthalidone had a lesser incidence of congestive heart failure, and that is not surprising. Now, in Mr. Fit trial, which was done for a longer period of time, regression of left ventricular hypertrophy was a little bit more prominent with chlorthalidone compared to hydrochlorothiazide. Why? Because it lowered the blood pressure much more and it had a 24 duration of action. Not pleiotropic effects, but it is a hemodynamic effect. Now, this is a question that comes all the time on electrolyte imbalances with diuretics, and Brian also mentioned about it. During the 7-year observation in the Mr. Fit trial, the potassiums were very similar between hydrochlorothiazide and chlorthalidone. You can't find any evidence better than this. No study will be ever done in our lifetime which will follow the patients for 7 years. Very, very important. This is a small study that we did in Dallas. My former partner, late Dr. Kaplan, had asked me to do this study on the magnitude of blood pressure fall between hydrochlorothiazide and chlorthalidone. We used a higher dose at that time, not knowing lower dose is effective. At that time, we demonstrated the fall in blood pressure was a little bit greater with chlorthalidone, although hydrochlorothiazide also lowered the blood pressure. Now, Dr. Parikh is sitting here. He was the principal author of this paper published in Journal of American College of Cardiology, where he and his colleagues have shown that low-dose chlorthalidone, 6.25 milligram, was as good as normal or higher dose of hydrochlorothiazide, published in JACC about 6-7 years ago. Now, the last trial, the latest trial to compare hydrochlorothiazide with chlorthalidone was published in New England Journal of Medicine last year, exactly a year ago, comparing hydrochlorothiazide to chlorthalidone, so-called diuretic comparison project. This is one of the few studies that compared head-to-head hydrochlorothiazide, chlorthalidone. What they have concluded was hydrochlorothiazide 25 milligram and chlorthalidone 12.5 milligram were very, very similar the first time. But there are some important differences. In patients with pre-existing cardiovascular disease, however they defined it, the number of events was lower in patients who were on chlorthalidone compared to hydrochlorothiazide. This did not come up clearly in the paper, but when I spoke to the investigators, that's what they told me, and I looked at the data. So if you have pre-existing cardiovascular disease, chlorthalidone was slightly superior to hydrochlorothiazide. And this is a very important point, ladies and gentlemen. Patients were on hydrochlorothiazide for a longer period of time, whereas chlorthalidone patients were on a shorter period of time. So the argument was whether short-term exposure to chlorthalidone is as good as long-term exposure to hydrochlorothiazide. Very, very interesting observation, and I think, Anil, we wrote a letter and an article on this. The duration of treatment was a very interesting thing. Not a bad paper, ladies and gentlemen, but I was surprised that it was published in New England Journal of Medicine. Now, about CCBs, the guidelines, not unexpectedly, they recommend long-acting CCBs. That is to be expected. In India, unlike other countries, you have different generations of calcium-blocking drugs. In US and Canada, they don't. In India, in addition to amlodipine, nifedipine, you have cilnidipine, azilnidipine. Each of the new generation CCBs has longer duration of action. All the new CCBs were developed in Japan to prolong the duration of action. Now, when you compare the new generation CCB with amlodipine, they appear to be very similar in fall in blood pressure. For example, azilnidipine, which is available in India, is as effective as amlodipine. The only thing is, unlike amlodipine, azilnidipine has a slight reduction in the heart rate due to its neural inhibition of the calcium blocking drug, a slight reduction in the heart rate. And the proteinuria that has been reported with amlodipine, you don't see it with azilnidipine because of its renal effect. So efficacy on blood pressure is very similar, but the efficacy in the heart rate and on proteinuria are quite different. Now, lastly, ladies and gentlemen, this re-upgradation of beta blockers in the new guidelines. Beta blockers have multiple effects on cardiovascular system, multiple effects, although we only look at the blood pressure and heart rate, but they have multiple effects which have been studied for a long period of time. A plethora of beta blockers have been developed, and the new generation beta blockers which are recommended by the new guidelines, vasodilating beta blockers, whether you want to call it nebivolol or whether you want to call it bisoprolol, these are the new generation beta blockers, although there are no outcome trials. There is one small outcome trial with nebivolol called seniors, but otherwise they're shown to be mechanism of action is improvement in endothelial function. Dr. Welton mentioned about atenolol not being cardiovascular protective, and the question is maybe its effect on blood pressure is not that great for 24 hours. And this is a 24-hour ambulatory blood pressure study comparing atenolol with a vasodilating beta blocker recommended by new guidelines. You will notice the new generation beta blockers have a better effect on 24-hour blood pressure compared to atenolol. And one more thing I want to mention, atenolol, whatever formulation you use, it doesn't matter. It has to be given twice a day. Does not matter, be long-acting, whatever you want to call it, slow release, does not matter. You have to give it twice a day. Same thing with some other antihypertensive drugs, you have to give some of the drugs twice a day. One thing, lastly, is when you lower the blood pressure, you also have to keep an eye on the heart rate. And you have heard some conferences recently from Europe where heart rate is an important predictor of cardiovascular prognosis. So you don't want to have blood pressure control, but heart rate not controlled. The best prognosis here you will see is those individuals where the blood pressure was lowered and heart rate was also lowered. Both of them have to be reduced because to use an old term, nobody uses anymore, double product. These days with CT, MRI, nobody wants to use these hemodynamic phrases like double product. So it reduces the cardiovascular stress. Lower heart rate, lower blood pressure, that means you're sedating the heart. But your blood pressure is low, but heart rate is high, you're agitating the heart. You don't want to agitate, you want to sedate the heart in order to prevent coronary perfusion. So, ladies and gentlemen, Mr. Chairman, in conclusion, either you're born with predisposition to risk factors, or you acquire risk factors due to environment that was suggested. So when you have only risk factors, you are a person. You're a person with blood pressure, you're a person with diabetes, you're a person with hyperlipidemia, you're a person with high body weight, you're not a patient. But if you don't take care of the person becomes a patient with cardiovascular disease, coronary heart disease, cerebrovascular disease, CKD. So he is converted from person to a patient. If you don't take care of the patient, then he or she gets disabled from stroke, chronic kidney disease, what have you. Person, patient, and disabled. But the best window is when he or she is still a person. That is the time where you prevent transformation into a disease and to an event. So ladies and gentlemen, in conclusion then, in the time that was allocated to me, I have given you a very narrow briefing about the recent or the latest hypertension guidelines. Goals have already discussed. I talked about the therapeutic choices that can be made in order to reduce the cardiovascular risk. And guidelines come and go, but unless we follow, it has no meaning at all. So one should try to implement guidelines as much as possible, and that is the reason why one has to make them simple and simple for primary care physicians. And last comment I want to make is many of the guidelines in the past have been made to the advantage of the specialist, not to the primary care physician. It has to be for primary care physician because those are the people who are taking care of people when they walk in. So I hope that the future guidelines will become simplest so that it becomes almost a no-brainer to use them in clinical practice. With those remarks, Brian and my colleagues, I thank you for your attention and have a good evening. Bye-bye.